everyone. Thank you for joining the Leading Age Georgia webinar series, Polst. And I want to introduce our two speakers today, Dr. Adrienne Mims and Dr. Anna Skold. And without further ado, I'd like to get this webinar started. If you have any questions, please use the chat space. If you would like to unmute your lines, press *7. At this time, I will mute all lines. All right, Dr. Mims, please feel free to take over.
Thank you very much, and it is a pleasure to be here with you today talking about the importance of end-of-life discussions. We'll be focusing a lot on the Polst, Physician Order for Life-Sustaining Treatment. You may have heard about this, but may have had some questions about how to implement it in your personal lives or in the settings in which you are responsible for overseeing the lives of Medicare beneficiaries and other people. So we hope that today will be an opportunity to describe a lot of the information. Neither Dr. Skold nor I have any financial relationships to disclose. We are both very passionate about this subject and do not receive separate funding for promoting this use. We're hoping today that we will give every every attendee on this presentation a deep understanding of what this Polst is for and how to use it in your setting. We're going to focus a bit on some of the common barriers and misinformation, and I'm sure that will touch on some areas of concern with you, but we hope that if we're not touching on all of your questions, please feel free to enter them in the chat bar. I'd like to start with a real case. This is a case of one of my patients that I took care of in my primary care practice. I'm a family medicine physician and geriatrician, and in my outpatient clinic, Ms. Sadie Todd was one of my dear patients who came to see me over several years. And as you see on here, she was an elderly woman, not atypical in that she was on many medications and had a lot of medical problems. She did have a daughter who lived with her in the house. It was just the two of them living there. And she needed assistance over time with doing all of her cooking, bill paying, driving. And later she needed some assistance with bathing and dressing. It was good that they had a one-story home and only had 2 steps to get in and out of their household. So that she and her daughter were surviving quite well for quite a long time. I saw Mrs. Todd in the clinic, and over time, she became sick with heart failure and had to be admitted to the hospital. I saw her in the hospital. When she was discharged from the hospital to go to a rehab facility, I saw her in the rehab facility. We determined for a while that she needed to come down to assisted living before returning back to home. And in each one of these settings, including home care, I took care of Mrs. Todd, including her final period of time when she was to go to hospice. When we made the decision for her to go to hospice, it is with the discussion of her and her family. And this was in keeping with her prior decisions when I first met her of wanting to be at home with her family. She died at home in hospice. So keeping Ms. Todd in mind as we go through the rest of the presentation, she's probably like many of the people in your facilities that you care for. So I want you to keep her in mind as we move forward with this discussion today. In Georgia, we're very blessed to have some documents that are in place for healthcare advance directives. As early as 2007, a law was passed in Georgia that combined some of our legacy documents that we've had before into one document. It was very good that it brought together the prior living will and other documents, and that now in one place a person could say who was their healthcare agent to speak for them if they could not speak for themselves. It said what they wanted and didn't want in terms of the treatment preferences. It also went as far as to describe whether or not they wanted organ donation, whether they wanted to be buried or cremated. And it was a legal document with two patient signatures. One patient signature and a witness. I think it's very important to highlight here that you do not need a notary or a lawyer. Some people may choose to have a lawyer assist them in completing advance directive documents, but it is not a requirement. The Polst, or physician order for life-sustaining treatment, translates that healthcare advance directive that I was discussing on the prior form into a medical order. Now, the prior document is very important because it is written in lay language and allows the family to have a discussion. That particular form is not in a medical order written by a physician, and thus the prior order does not allow the EMS nor emergency room physicians to know what to do, or even the nurses in long-term care what to truly do in the case of an emergency. So it truly activates that patient's advance directives, and all of the members of the healthcare team, this is used as a valuable communication tool stating, yes, this is what they wanted, and now it's a medical order for them to do. Now, it will go with them. If they use it, if they complete it in their home or senior high-rise or wherever they are currently living, but then have to be transported by EMS or go to the nursing home or hospital, it goes with them. And because it's a legal document in the state of Georgia, it must be honored by all healthcare professionals, nurses, EMS, physicians. People are wondering, is it really the law? Well, yes. As I mentioned before, there were advance directives that were passed previously, and it was updated later. But the physician order for life-sustaining treatment, Polst, the Department of Public Health was asked to take over the development of the actual form in 2012. And in 2015, a subsequent law was passed to put more teeth to determining, yes, people are supposed to acknowledge and use this form, and whoever uses this form are free from prosecution. They have immunity from prosecution if they follow this form. So what we would like to do as part of members of the Georgia Polst Collaborative is to promote throughout the state that we feel that the gold standard for patient care is that everyone should be able to have their end-of-life preferences discussed, documented, and followed. And in fact, this should be very routine. So if you go into a medical setting or if you're doing intake for your new clients, we want it to be as routine as asking them about, do you have allergies? Have you completed a form to document what you would like to have happen with you at the end of your life, where that would be, who would talk for you if you cannot speak for yourself. We want that to be the gold standard that happens in every encounter, and so we do understand that it means teaching people about these documents and making them comfortable in using them. So we talked about two different forms, the Georgia Healthcare Advance Directive and the Physician Order for Life-Sustaining Treatment, or Polst. I'd say that everybody on this phone should have an advance directive. In the state of Georgia, it's legal for a person to determine what their wishes are from an advance directive as long as they are a consenting adult, which is over the age of 18. They complete it themselves, and they're talking about what they would want to have happen in the future. What if I was in a massive car accident? What if I had drowned and I'm now in a coma? So they're saying what they would like to have happen in the future. And we in Georgia know of some of those cases. Most recently, Bobby Christina, who had not had such a document, and her family quarreled tremendously about what to do with her because they did not know her advance directives. Whereas the Polst is very specific for patients who are toward the end of life or very seriously ill or frail. It is completed and signed by the physician and patient, and it is specific medical orders. So if a person's in a hospital or in a nursing center and they want to know, should they have this medication, should they have this treatment, how should they be treated, it is a medical order. But the patient is involved in this, and that they also sign it, or their representative signs it with them. Now, this is an example of the Polst. You can see in the upper left-hand corner, Department of Public Health, and then the Georgia logo of the Polst in the upper right. There are two websites that you can easily access and download these, and you can order them in bulk at these two websites also. All of the different versions of Polst across the nation are very similar in that it has these 5 sections. And Dr. Skoll's going to go over these sections in more detail. But I wanted to emphasize that this is not just a Georgia initiative. This physician order for life-sustaining treatment is a national initiative, and we are implementing it here in Georgia. When you think about that first grid I showed you about a healthcare advance directive versus a Polst, the question comes in, at what point do you need one versus the other? And this schematic really addresses that. That, as I said, almost everyone on this phone should complete an advance directive. I have one myself. I travel a lot around the state, and I want to ensure that my wishes are honored. My husband, who is from a different culture than mine, does not have the same wishes toward end of life. And so he is not my person that I would have speak for me. Rather, it's my sister who understands and agrees to honor my end-of-life wishes. But I did tell my husband, and he understands what I would like to have happen. But later, as I advance in age, or specifically my mom, who is still living, she's completed an advance directive. We review it regularly, about once a year, usually around her birthday. And she's determined that I am the person to be her healthcare agent. Should she become frail or diagnosed with cancer, we will move forward and complete the Polst to make sure that her wishes are honored. It's important to have the conversation. Most people, if you ask them, they want to die at home. I was recently at a senior center in Atlanta with this discussion, and there were 70 seniors, probably average age of 80 in the room. And I asked them, how many of you would like to have the end of your life at home as opposed to being in a facility? And although this statistic was 70%, I'll tell you, 90% of the people in that room raised their hand. There were a few who that was not their preference. Most people still die in the hospital, in a facility, and not in the care of their loved ones. People say that they want to write their wishes down so that they can be honored, but few have done this. People say that if they're very sick, they are hoping that their physician will bring up the discussion of end of life with them, as opposed to only offering more treatment when it's not really plausible. But people admit that very few of them have had those end-of-life conversations. Dr. Atul Gawande is a very gifted surgeon and storyteller. He wrote this book called Being Mortal. I would recommend that you add this to your reading list. It's a wonderful book that describes the whole history of how we take care of seniors as they age in America. And it gives this historical perspective of how we've moved toward assisted living and long-term care facilities. And toward the end of the book, he begins to describe the phenomena of people moving from dying at home to dying in the hospital. And what he noticed was that through his studies, he found that people who had discussed their advanced care or end-of-life decisions with their clinicians, they were able to have them honored, and they died in peace with their family around them, and a lot of their decisions had been made. But what I tell patients, especially those when I was in the senior center talking to these seniors, that the default, if you don't make these wishes known, is that you will be in an intensive care unit with a tube in your mouth, a tube in your lungs, a tube in your bladder, lines in your veins. The people around you will be in sterile clothes, and your family will be down the hall in a waiting room. That is the default if you don't make your wishes known. And most people are surprised about that. So to move away from that default, you need to make sure that advanced care plans are done and honored. So let me turn it over to Dr. Skold to tell you how to do that. Dr. Skold, are you on mute? Dr. Skold, are you with us?
The conference has been unmuted.
Okay, I'm not on mute, but somebody I think had muted me. Can you hear me now?
Okay. Yes, we can. Thank you.
Okay, thank you. As Adrian said, thank you, Adrian. My name is Anna Skold. I'm an internist and a palliative care physician, and I use the Polst regularly with my patients in the outpatient palliative care clinic. And we'll continue the discussion and break down the different parts of the Polst. But to start the conversation, generally we don't jump to a Polst until we've talked about what really is important to patients. So creating an entire advanced care plan involves talking about who would speak for you, what those goals are, and then the Polst is really at the end of this conversation. So if we talk about step one is always asking permission and inviting those that a patient states are most important to them. Step two is checking understanding what does the patient, do the family members understand about the medical issues that are going on, and identifying values that are important. So just as Adrian said, most people wish to die at home in peace, but there are values that are different, such as some patients don't want to die at home. There are cultural values there that need to be identified. Some patients would agree to being on life support for a short period of time just to have family at their bedside before they died, but they wouldn't want long-term life support. So identifying some of those values is a very important point. The next thing is to designate a decision maker. So when I talk to patients, the first thing I always talk about is who knows your medical history? Who do you trust? Who would you turn to be your medical power of attorney, to be your voice? And we talk very much about being the voice of the patient. And then once that has been discussed and talking about preferences at the end of life has been discussed, when all those things are much more clear, then we talk about a Polst form if someone has an end-stage disease, a very serious illness or frailty. And we'll come to this later, but the key question is if you could ask the question, would you be surprised if a patient died in the next year? And you could say, no, I wouldn't be surprised. That would be a flag for you to start thinking about Polst. So the logistics, we talked about this. First, it's really just laying the foundation, the conversation with the patient and family, creating the advance directive, and asking the surprise question. Then it comes down to how to. So in our clinic, we have the Polst form readily available in all exam rooms. We've educated physicians and staff about how the form has to be presented and who has to sign it. So we do have social workers in our clinic who can talk about the Polst and go through the Polst. But because a physician must sign it in the state of Georgia, not even a nurse practitioner or a physician assistant, a physician must still sign the form. So there are other people who can go through it, but the physician must be comfortable signing it. Then we talk to family about where the Polst form should be kept. So in a home, it should be kept on or inside a fridge, in a facility, on a chart, sometimes in the back of the door of a room. Copies are valid, so I talk to patients about having multiple copies. I had one patient who wore his Polst around his neck and told every human being he came across what it was and why they should honor it. I have other family members who keep it in wallets, who keep copies in their car, but they do keep usually the original on a fridge or somewhere like that. That's where EMS is supposed to look. Then it's talking about staff training on Polst. So if a patient, say a person is in a facility, so what would happen if someone called 911 at 3 a.m. for this patient? Would everyone who's working in that environment know that the patient or the person had a Polst? Would they know to tell EMS where to look? So this is one thing to start considering is, do you have a checklist for your facility? Do you have a way of knowing which patients might have a Polst or who might have a Polst? So not just training about Polst, but also talking about the logistics. So talking about some barriers and misinformation. Just as Adrian said, an advance directive does not need a lawyer or a notary and is free in the state of Georgia. You only need 2 witnesses for the signature. And just so you know, those witnesses do not need to know what's in the form. They are only witnessing the signature. And those witnesses should not be family members or healthcare providers. So I always tell patients it's great to use friends, neighbors, church members. Complete strangers in a waiting room that is acceptable, and we have done that before. They are only witnessing a signature, not content of the form. Other misinformation. EMTs cannot follow an advance directive. It's not an order. Family members don't understand that. They think, well, if I have the advance directive or I am the medical power of attorney and EMS arrives, then if they are do not resuscitate, even though there's no order, I can say that. The fact of the matter is EMS must follow a written signed order, and that's where a Polst comes in. Polst is an order and can and should be followed by EMS. It is the law that they should follow EMS, but we still must advocate and train everyone. So we're asking with this education that everyone start educating staff, educating everyone around them. Unlike an advance directive, a Polst must be signed by a doctor. That is the difference. That is what activates this as an actual order. And then Polst is protected in Georgia. The 2015 law protects those following a Polst in good faith, similar to Good Samaritan laws. But this protects physicians, this protects EMS, this protects anyone working with this person, this protects hospitals, this protects everyone. So to come back to Mrs. Sadie Todd, Mrs. Todd and her family sit down and discuss her goals of care with her physician, who's Dr. Mims. She's very clear she wants her daughter, Mary, to be the medical power of attorney because she lives close by and goes to all her appointments. And then when she returns home from assisted living, she is living with her daughter, Mary. Mrs. Todd's primary concern is to stay somewhat independent. She knows she needs help with things, but she's still able to attend her church and participate in outings and activities with her daughter and with friends. And she also states that if she cannot recognize any of her family members, that she would want comfort measures only at that time. When asked, whenever time is short, where would you picture your last days? She states, in her own bed, surrounded by family, enjoying music and ice cream. I think this is a really good question to ask people. It doesn't give an expiration date on anyone. It's very, it's a more benign question, but it's a question that can be asked of everyone. So if you had a very short period of time left in your life, whenever that is, where would you be? How would it look like? So at this point, Mrs. Sadie Todd creates an advance directive. Mary is the medical power of attorney. A son is an alternate. And preferences at this time include no artificial interventions at end of life or in settings of permanent vegetative state or coma. But again, this is a preference, not a medical order. So Mrs. Todd transitions through multiple different settings over time, and she does end up with worsening heart failure. Dr. Mims, her primary care physician, states that she would not be surprised if Mrs. Todd died in the next year due to her worsening heart failure. At this time, Mrs. Todd is living in an assisted living facility, and a new family meeting is held, and the social worker at that time has some further discussions and starts the conversation about Polst. They discuss events of the last year and what would happen in the future or could happen in the future, and the following is decided. So if someone calls 911, which usually happens in the middle of the night, she would want to go to the hospital for IV diuretics. So if she had a lot of fluid on board for her heart failure, she would want things like Lasix. So medicine to remove fluid from her lungs. And for things like antibiotics, so if she had pneumonia or urinary tract infection, she would want antibiotics. But she knows she never wants a breathing machine. She never wants dialysis. And if her heart and lungs stop, she does not want somebody pushing on her chest to try to get circulation back. So no CPR. She wants to do things that might be easily reversed and get her home, but nothing that would make her uncomfortable or be long and drawn out with continued decline in her functional status. So at this point, a Polst is very appropriate. So if you look at a Polst form, it's broken down into different sections. The very top part, the name and the date of birth is placed, and then it goes down to Section A. So I actually like talking to patients in the same way as the Polst is set up because I find that patients don't understand that CPR is only used when someone has died. I actually had a conversation this morning with a family member who didn't understand that do not resuscitate meant that only when somebody's heart and lungs had stopped and they died, we would not push on their chest. He was concerned that if his wife had fainted or had low sugar or something like that, that we wouldn't do anything. And I said, no, that's very, very different. So I always use this language. So if a patient has no pulse and is not breathing, what would they want? And Mrs. Todd wants to allow natural death. you check that second part. Allow natural death. Do not attempt resuscitation. So section B is about medical interventions, and it says right next to that, patient has a pulse and or is breathing, so they are alive. What would you want done? And Mrs. Todd chooses limited additional interventions, which means if 911 is called, she'd be taken to the hospital and things such as IV medicines like IV Lasix or IV antibiotics would be used. However, she wouldn't go to the ICU and get CPR, mechanical intubation, or dialysis, or any of those more invasive procedures. And just so you know, you can write in additional orders there. So I will have patients who say things like they want full treatment, like they want mechanical ventilation if they're still alive, but they know that they don't want dialysis. So there is a way to write certain things in too. So in this case, Mrs. Todd has chosen the second one, limited additional intervention. Section C, antibiotics. Mrs. Todd wishes to have antibiotics at this time, but we should know who may not want antibiotics. So data tells us that antibiotics can prolong life, but decreases quality of life significantly in end-stage dementia patients with pneumonia. We also know that there are times when going to the hospital for antibiotics will not be helpful. So in very end stage of life, there can be times to not use antibiotics also. For many of my patients, we use the second one, determine use or limitation of antibiotics when infection occurs. And that means on a case-by-case basis. But in this case, Mrs. Todd wants to write in the third one, use antibiotics if life can be prolonged. Section D. So Mrs. Todd states she never wants a feeding tube, but she's very clear she loves ice cream. So she states with a smile, as long as I can eat, let me eat. She wants a time-limited trial of IV fluids to see if it will help, because that's happened once before when she's had too much Lasix and she got dehydrated. Then she needs a little bit of fluids back. So she states if it'll help, please try it, but not indefinitely, because she knows it can hurt her too. And to be clear, patients sometimes get confused about feeding tubes and fluids. They think that they're going to starve at the end of life, and we always explain at the end of life, we will always feed people. We will always keep their lips moist. We will always take care of them and give them the things that they want. This is really talking about artificial measures. And just to note, feeding tubes have not been shown to benefit end-stage dementia patients and have instead shown harm. IV fluids at the end of life can cause shortness of breath, swelling, and overall discomfort, and in general causes suffering at the very end of life. I try to normalize these things. Patients do seem to understand that, we didn't have tubes. We didn't have IV fluids. We didn't have feeding tubes 100 years ago. And so when we get sick, we don't always want to eat and drink as much. And that actually is very protective. So at the very end of life, when we don't feel like eating and drinking very much, the salts in our bloodstream go up, our kidneys slowly shut down, endorphins are given off by our liver. We don't have fluid and things backing up in our skin or in our lungs, and we actually can go very peacefully. And when we try to interfere in that process, we actually cause discomfort. When I put it in that type of language, people do understand that medical interventions are not meant to be used at the very end of life or can cause a lot of harm or discomfort. So these are our references and resources, and we hope that you enjoyed the conversation, and we would be very happy to take any questions at this time.
Thanks so much. I've unmuted all lines, so you could go ahead and ask away. I do have one question. So the Polst is in place, and the person is experiencing some of the things that you talked about that comes towards end of life. What happens if the person changes their mind in terms of their directive? They're able to articulate and want to make a change.
All advance directives, including Polst, can be changed at any time. As long as the patient has capacity and they choose to change something, you would just make a new Polst, a different Polst, and the first one would be invalid, and it's best if you write invalid and do that in the chart if it's in there. But the newest dated Polst is the one that should be followed.
What's your recommendation in terms of protocols and policies for example, for independent living? I use that term loosely because we know we have a lot of folks that are aging in place. What would you recommend in terms of a policy for a social service coordinator, for example, in maybe an affordable housing community or a market rate community where typically they don't have or may not be aware of a person having a Polst and want to figure out how to create language in their assessment tool?
Adrian, do you want to take that one first?
Sure. So usually in many settings you have some folder or documentation or intake about your residents. And one of the questions you might consider having is, have they chosen to create a form that expresses their end-of-life wishes? So it's not a requirement, but if they have, and would they like to share a copy of that information with the facility so that the facility can ensure that it's answered, that it is upheld. We recommend that people make a copy of it and post it on their refrigerator. And I think the second thing is, if people have made advance directives that in these different locations, that you have some type of staff policy of what you would do when 911 is called to your facility. That if 911 is called to your facility or emergency people show up at your door, and even if you didn't know they were coming, to find out who are they coming to see and to look in the folder to see if the person has a document. So those are some things to consider doing, but it's totally optional. I think it's one part to encourage your residents to have the documentation and that they make it accessible to anyone that comes to their door, and that if you want to encourage them to have that documentation, it would be helpful that there is a centralized place that anyone who is staff kept a copy. That is not required. It is truly the responsibility of the resident. Thank you.
And I'll just add, the patients that I complete a Polst with are very clear on their wishes. So I think Polst is best done when multiple conversations have been had and people are very, very clear what they want and don't want. And then I empower patients to be their best advocate. So all of my patients who have had a Polst and come into the hospital or a different facility have, I tell about one patient who had severe lung disease and was in his 80s and could barely breathe but was awake with capacity. And he had the Polst on his chest. He was holding on to it and waving it as EMS was rolling him into the ER. He could barely speak, and he was pointing to it saying, "This this, follow this. As I said, I had a 90-something-year-old who wore it around his chest in a little kind of name badge, clear folder, and was also very clear on telling every human being he was friends with that it was there, and if he fell down in the middle of the street or the middle of dinner drinking a glass of wine, that it was on his chest when 911 is called. So I think really making sure that people are their own advocates also, as well as making a checklist or having some kind of system in a facility is really important.
Thank you. Any other questions out there? Okay, well, hearing none, I just want to share that on February 22nd, because I know it's a lot of information, we did have some technical challenges getting connected. So I want to let you know that we are going to reconvene a conversation during the service coordinator audio conference on February 22nd. More details will come out on how to call in for us to have more dialogue around this conversation. I'd love to learn what you all are doing in terms of what you're adding to your assessment tools that we could share with others in our network to make this a priority and to give this just wonderful tool to make sure it gets in the hands of everyone, and not just the resident base, but even the staff that you work with to make it a whole community effort. Thank you to our speakers. We do appreciate everyone's time, and have a wonderful day.
Thank you.
Thank you.